So I request all of you to make yourself mute because otherwise the disturbances will come. So today we have our speaker, Dr. Om Srivastav, who is the consultant, infectious
I'm mute.
disease specialist, professor and HOD of DY Patil Medical College Hospital, New Mumbai. He is the member of State Advisory Committee of H1N1, member of State Malaria Death Review Committee, member of Maharashtra State Committee on Prevention of Communicable Disease. He is the panelist for COVID-19 cell, Government of Maharashtra, and lot of publications internationally and nationally he is having. With Dr. Om Srivastav, we have today our case study presenter, Dr. Ankur Gupta. Dr. Ankur Gupta is working as a consultant intensivist and head of critical care and emergency department at Apollo Hospital, Indore. And he will be presenting you some cases on Thymosin Alpha, Immunocin Alpha. Today we have our panelist, Dr. Sethi is there, who is Dr. Adarsh Sethi, who is our medical advisor, who has done his MD from Banaras Hindi University, and he is now a medical advisor of Gufic Bioscience Limited, Mumbai. And Dr. Navneet is also in the panel, who is a MD Pharmacology from Manipur. As you know him, most of you know him. So I welcome all the speakers and all the panelists in this webinar. All of you know that is a very different type of situations which is happening in the entire country, entire world. And last 5 months, almost the world is just shut down. Professionally, personally, everybody has been affected. Today, I was just seeing the television that around 2.5 crore of the population are being infected with COVID-19. In India, around 35 lakhs patients are there, where we have got more than 60,000 deaths. From patients, it may be your family member, it may be your relative, it may be your patient, your neighbor. From death also, it has happened. I'll give the example of myself. I was in severe condition of COVID-19 and I lost my mother also a few days back. There are so many patients from Gufic who had been treated, they came back, and it is a big pandemic which is happening. So in this situation, we thought that as a responsible pharmaceutical company, we should also search the avenues and solutions to tackle this disease better with our available resources. And I am very thankful to our Executive Director, Mr. Pranab Choksi, who is a visionary leader, our CMD, sir, Jayesh Choksi, who both of them are watching this program. Welcome to you, sir, and thank you very much for giving us guidance to come with some of the solutions. Thymosin alpha is a product, or it is a molecule which has been approved by US FDA 40 years back. It is around 40 years back, and it is approved by DCGA also for the other indication. But after the resurgence of this COVID-19 across the globe, some of the pharmaceutical companies and researchers have started working on it. And the first data which we have got from China, that is with 2000 patients data on COVID-19, and then the data are available internationally, clinical trials are gone, and we as a responsible company, we have got DCGI approval for phase 3 trial double-blinded. Gufic is the first company to get it, and there are 6 centers in the country the trial is going on. We have started the investigator-initiated trial also in 3 centers in Bombay. And this product specially aiming to modulate the immunity. It is told that it is a very perfect immunomodulator. So in the subsequent slides and our respective speaker, Om sir will take you through. Only thing I will just give a brief that Immunocin Alpha, that is Thymosin Alpha, works on innate immunity, acquired immunity, and it has also its virucidal action. As a result, not only for COVID-19, for a prophylaxis, for severe, moderate, also. Now, Samrat, to coordinate and to hand over the session to our respected speaker, Dr. Om Srivastav, today. And this webinar series will continue for 3 series. So on 12th September, Saturday, 7 o'clock, we have kept the second phase of this series where we will be talking much more on T cell. And in October, we'll be talking on inflammation versus infection, because we all as a physicians are now much more worried about the infection, but inflammation part is not being taken care of that way. So that way also we are planning it as a series of CMEs and webinar. So today the topic will be much more roaming on the molecule, that is immunocin alpha, that is your thymosin alpha, whether it will give a paradigm shift to the COVID-19 patients. So over to Samrat now, and Samrat, please hand over the session to respected sir. Thank you, sir.
Yeah. Hello, doctors. So I will be now inviting our first speaker, Dr. Om Srivastav, to please come and. I will request Dr. Om Srivastav, our first speaker, to please start sharing his content.
Okay, so thank you, Dr. Devesh Das. Thank you, Samrat.
Yes.
This is a very exciting time for treatment modalities being developed in COVID-19. I think that amongst all the modalities that have come to see the light of day to this point, I think that Thymosin Alpha is probably going to be the one molecule that all of us are of interest, with a huge amount of interest. I'm going to request Samrat if you could have the slides uploaded, and I'm going to request somebody to change the slides. While the slides are getting uploaded, say a few quick words about why Thymosin Alpha is so important. Okay, so I was going to say a few introductory words about the treatment of COVID. Now, if you look at all the treatment modalities right now, you'll find that amongst all the pharmacotherapy that's available, whether it is, if you start from the beginning, whether it is hydroxychloroquine or chloroquine, or it is lopinavir, ritonavir, it is ivermectin, doxycycline, or it is something like colchicine. All of these have had significant but small studies on their efficacy. And unfortunately, none of these have been able to come into the mainstream of a treatment. Now, molecules we use right now, there is also remdesivir, there is also favipiravir. But remember, both these molecules, none of them are actually curative. The only benefit that they have shown, which is not a small benefit, it's actually quite significant. The benefit that they have shown is that there is reduction in the total duration of illness. Now, when you've got somebody who's very unwell in ICU for about 7 days, by reducing their illness by about 2 or 3 days time, that's a significant reduction. But that's the extent of what both these drugs will do. And so that brings us to something like Thymosin Alpha. Why is Thymosin Alpha the molecule that we are looking at? So when we go through the slides, I'll tell you a little bit about the immunology of COVID and what it is doing to the immune system of patients. So while we are still uploading the slides, let me share with you. The thing that happens is that COVID is going to deplete the patient's two major elements in their immune response. That is the T cell and there is their natural killer cell. Also, there is interleukin 6, which gets upregulated. But there are probably a number of other mechanisms that we don't know enough about. We probably think we know about it because it's there on paper. But in reality, there are several other benefits that are there with thymosin that we probably don't know enough about. But we definitely know that when you've got a patient with COVID who is likely to run into a either in the ICU or in the ICU. While we talk about the immunomodulatory effects, we probably know only a small fraction of what a molecule like thymosin alpha will do, and that there are probably a lot more benefits, a lot other benefits of the thymosin molecule. We'll probably know as time goes on. Now, already there are trials that are in place in the country. There are other places where the trial is about to start. And we would like to see as to what comes out of these trials insofar as the precise positioning of thymosin alpha. So like any other molecule, you've got to position it correctly so that you're able to offer the maximum benefit to a patient. And because of this one particular feature, it is probably most likely, and this is my own personal point of view, it's probably very likely to be beneficial to patients in the early part of the disease rather than the severe disease or the moderate to severe disease. I think there is a role for starting thymosin alpha based on the literature available. There is a role for starting thymosin alpha in the early part of the disease. Now, when you look at now the slides, that are about to come up, thymosin alpha has been actually used successfully in a number of other conditions. That includes hepatitis B, that includes hepatocellular carcinoma and some skin conditions. In all of these conditions, it has been shown to be of significant benefit. But you can't extrapolate the benefit of one condition onto another condition, and that have to be demonstrated in its efficacy towards COVID alpha. So I'm going to get started. Thank you for loading up the slides. Can we get started? Next. Okay, so when I was talking to Dr. Navneet Vadhva, we consciously made a decision that we will try and limit the total amount of theory, all right, and that we'll try and keep it as clinical, as practical as possible. And this is where things are, So COVID has two separate phases of the response. One is the viral response, which is in the first about 7, 8, 9, 10 days, maybe up to 12 days. And then there is the inflammatory response. That may start as early as the third or the fourth day, but it is traditionally accepted to be one of the two phases of COVID. Something that we accept and that the immunomodulatory part is very important in both these phases. Let's go to the next slide. There is a fair number of... I think I've just been unmuted. Can you hear me? Can you hear me?
Yeah. Yes, sir, we can hear you.
Okay, so can we go to the next slide, please? Can we go to the next slide, please? Yeah, okay. I think we've gone ahead. Can we go back one slide or two slides? Okay, yeah. So again, going back to, that should be sufficient. Going back to what are the phases of the illness? There is a viral phase in the initial part of the first 7 to 10 days time, sometimes 12 days time. And then there is the non-viral phase, which is the inflammatory part. Now, the inflammatory part is mediated by a number of cytokines, interleukins, tumor necrosis factor, alpha. All of these come into play. And that when we look at certain, immunomodulatory therapies, you'll have to look at which is the immunomodulatory therapy that can cover most of these things. So when you've got an agent like say something like one of the MABs, not itolizumab, but tocilizumab, all right? Tocilizumab works only in a unidirectional single fashion, that is, it inhibits interleukin 6. As against that, the itolizumab works in multiple levels, multiple directions. But thymosin alpha, as we'll see as the slides progress, functions at even more levels. There are several levels at which it functions. And that is why it becomes important, because the inflammatory part of COVID is not going to be in a single level, in a single direction. And that is where whatever therapy is being employed needs to cover all these directions, or at least most of it, so that what kind of recovery is being expected may be the outcome that you desire. Next slide, please. Okay, so this is pretty much, yeah. All right. So these are pretty much, the theoretical aspects of what I have just mentioned to you. There are those things that thymosin alpha will do, and that is, like I said earlier, it is not clear. We'll probably know more after the trials are over, and when we start that time. So, while we are starting with clinical trials in the country, across the country, we probably need to look at what are in alpha over the next months, years, depending upon amongst us. Next.
Organizer, please unmute the participant. Please, the participant is possible in WebEx from your side, because it's going. It's just me. Every participant from your side itself is possible. Start discussing with others.
Is it better that we skip the slide? Is it better that we skip the slide? I have another commitment that starts at 8:30. What is it that the immune system goes through? The biggest problem that the immune system goes through with COVID, the biggest casualty that we know about as of now is that T cell and the patient's natural killer cell. These are the two parts that get completely wiped out, right? In a lot many ways, this is not very different to septicemia, to sepsis, because that is the one thing that happens with sepsis. When your patient's T cell population is completely wiped out, then the total amount of response, or the immune response to a pathogen is very skewed. It comes into a process whereby it is functioning at 2% of what it should be functioning at. Right? That's what is happening with COVID as well, with what we know. Very similar to septicemia, the total amount of T cell, which is the big cell that is responsible for preventing any infection going into your patient's system and becoming a major focus. When you've got a T cell dysfunction, the total response becomes very slow, less than 2%, 5%, somewhere there. That is the reason why patients go through multiple complications, more than one infection. That also is the reason why patients' recovery gets delayed by a few days, a few weeks sometimes. That also leads to the T cell function that would have normally, the entire generation of a T cell goes through a doubling time normally between 2 weeks and 3 months. But when you've got something like COVID and you've got something like septicemia, this T cell population can take even longer than 2 weeks time. And that is the time when, because there is virtually no protection to your patient because there are no T cells, that is the time it is not able to mount a response. Now, just a little bit of the understanding, there are two parts to your patients and your own immune system, which is the B cell and the T cell. All right. Now, the T cell, they don't have what is called an antigen presenting cell. That means the antigen has to be presented to the T cell for it to be able to mount a response. And most times this comes from the B cell. And because of this process of the B cell presenting the antigen presenting cell to the T cell, it then starts a cascade of other parts of your immune system. That means your complement studies, your natural killer cells, your helper inducer cells, suppressor cells, and your immunoglobulins. All of them are responsible for your patient's own immune system mounting a response that tries to help in the recovery and the well-being of the patient. So when you've got a situation where the patient's these components of your immune response are suboptimal or dysfunctional, then it becomes very difficult to have an adequate response. And that is when one of the problems is that because we are not quantifying the immune system, we tend to treat everything with an antibiotic. Everything gets treated with an antibiotic, which is a mistake, because the antibiotic is going to be of no use. It's like saying, look, I'm going to withdraw 100,000 rupees from my account, but there is no balance in the bank account. So the balance has to be there before you're able to use that account, right? It's very similar to this situation, that you are going to be having a patient who's got an immune dysfunction, especially in response to an infection like COVID. Especially in response to an infection like COVID. So as I was saying, COVID, there are other conditions like hepatitis B, like hepatocellular carcinoma, like some skin conditions where thymosin alpha has been shown to be efficacious. It is very clear. That evidence is very clear. But in COVID, there is new evidence that we should be looking at very seriously, because it is there. The evidence is there. It's definitely there on paper, and it has simply to be shown that it's going to be translating. Yeah, as you can see on your screen on the slide, there is clear evidence, but like I said, it has to be demonstrable in clinical context, and that will be what we're going to be hoping to see as to what comes out of these trials. Yeah. Until such time as there is coming back to how thymosin alpha is given, it is given as an injection once a day. It is sometimes given twice a day as well, depending upon how you'd like to position thymosin alpha. But in most instances, insofar as the trials are concerned, in most instances, there is going to be a 7 to 10 day injection once a day of thymosin alpha, and there may be a requirement to give that injection for a slightly longer period of time, depending upon what kind of responses you are hoping to expect, and that there will be a blood test to quantify how much of your patient's T cell or immune dysfunction is getting corrected in the immediate part, and how much is going to take a little bit longer. So again, the whole concept of positioning thymosin alpha is about making sure that there is an immune system that is exhausted or depleted or being dysfunctional because of the COVID infection. This immune dysfunction starts to recover at the earliest possible time, at the soonest possible time, and that patients who are likely to go into complications of COVID will have recovery as soon as possible. That can be done. That's the purpose of the trial, to be able to evaluate that the recovery of these patients is in the shortest possible time, based on the injections that you are giving of thymosin alpha. As of now, based on what we know, it's a fairly safe injection. It doesn't seem to be having any major side effects. There are some reported instances of local injection, kind of local injury, but that is expected with any other injection. Other than that, systematically, there are very few complications that have been documented, and that we should be able to see as to what comes out of these trials that have been in place. But like I keep saying, the outcome of these trials are going to be responsible for other trials to look at thymosin alpha and the effects that we probably don't know enough about at this time, to be able to document that and position it into multiple other indications, and not simply to say that there is a patient who's got a COVID pneumonia or a person who's gone to the ventilator because of COVID. I'm actually going to stop here and open the conversation for any comments or questions, just so that we can hear an alternative point of view other than just me talking and everybody else listening. So
Hello.
I'm going to stop here and I'm going to put it open for questions.
Hello. 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 Am I audible?
Hello.
Hello.
Yes, sir, you are audible.
Yeah.
Yeah. We will take up all the questions during the panel discussion part after the we have covered up with the case study presentation by Dr. Ankur Gupta. Then we will have the panel discussion over there. Over there, we will be taking down all the questions, sir.
Okay.
Okay. Thank you so much, sir. I will be requesting Dr. Ankur Gupta to kindly share his content.
Are you able to see my slides?
Yes, sir. We can see your slide.
Okay. So I'm extremely impressed by Dr. Om Srivastava for his patience, for being so calm in such a lot of disturbances and sparing such a time this COVID era. And secondly, very much agreed with Dr. Srivastava in saying that Thymosin Alpha may have a role in other than COVID also, where you have. So what was I saying? That I'm very impressed with Dr. Om Srivastava for his patience for such a long time, keeping his temperament cool in such a lot of disturbances and giving us a very beautiful presentation and overview of Thymosin Alpha. See, one more thing, very much agreed with him that Thymosin Alpha may have a role in other situations also where you need the immune system to function properly. So I will not be discussing on those details. My job is to present you a case, and I will be presenting the case of Dr. Vivek Joshi, who is my mentor, who is the head critical care and medical superintendent of Shelby Hospitals, and I think he has also joined the webinar. He's in the webinar itself, and it was a tough time. He is 46 years old, no comorbidities. He was on 23rd evening. He had done he was having some mild sore throat and mild fever, for which he told the call came and that I have done my CT. I have got my CT done, and whether you feel it's COVID. So we had a very small patch on his CT scan, and on the same night he got admitted just to make the family safe. He was not worried about himself because he told that it was a very mild case. Then from 23rd to 27th he progressed from mild to severe category. You can see here there was a small patch, but now the ground glass opacities were everywhere in the lung. You can see here, and his lymphocyte counts were reaching less than 6%. We'll see this. By 27 July, he was started on remdesivir. Earlier, he was on favipiravir and all ivermectin, doxy. Then he was also given tocilizumab because his IL-6 was started increasing. They reached up to 85. He also started requiring the NIV support. So let's see his TLC counts. On the day of admission, you can see the neutrophils were 69% and the lymphocyte were 19%, somewhere below 20. On 25th, the neutrophils were 90 and the lymphocyte count started decreasing 6%. There is when fortunately Deepak from your Gufi team WhatsApp me regarding Thymosin Alpha on 29th, I think. On 28th, I think he told that. And I was aware that lymphopenia is a very bad marker in COVID, and I was worried that the Dr. Joshi's lymphocyte count is less than 6%. So it was expected that in Indore it will reach around 2nd of August, but I requested him and he made it arranged on 30th. So on 30th July, he received the first dose of Thymosin Alpha. On 31st July also, the lymphocyte counts were 7%. Now, we have some evidence that in COVID, if you have lymphopenia, it predicts the severity of disease. You can see here some articles are published. It was on the 1st May that patient with severe COVID has a greater neutrophil count, higher neutrophil to lymphocyte ratio, and lower lymphocyte count than with non-severe COVID-19. Exhaustion of the T cell may predict severe progression of COVID-19 patients.
Hello.
Lymphopenia during COVID-19, it shows what can be learned. And finally, on 24th May 2020, lymphopenia and severe coronavirus disease 2019 systemic review, and they concluded that lymphopenia on admission was associated with the poor outcome in patient with COVID-19. So on 28th, on 31st till 31st, we were handling this table. The lymphocyte counts were gradually decreasing. The SARS condition were gradually progressing towards severe, and he was requiring NIV with 10 liters of oxygen, and we were worried. And on the 30th, we started with Thymosin Alpha. And you can see we started with 3 vials per day, means subcut. At the time, there was a study that the dose which was given to us was thrice daily single vial. Now it has increased to 2 TDS. And gradually you can see there was an increase in the lymphocyte count. On 6th, they were 22%, and on 11th, they were 27%. I can show you this was the handwritten reports by Dr. Joshi himself, who was monitoring these lymphocyte counts. You can see CD4 cells. Here they were only 347 absolute value. Here they were 462. Here it gradually increased. On 8th August, it was 884. Not only this, so the CD4 counts were very low, but they started increasing. And not only this, there was an increase in the lymphocyte count. He was showing gradual recovery also. Slowly his BiPAP support were taken off. He was on the rebreather mask. Then his oxygen requirements came down. His dyspnea came down. And fortunately, on 9th August, he was discharged. And he's sitting in the webinar now. So the lymphopenia is a very bad marker, and Thymosin Alpha plays a very important role, not only COVID, but also in other conditions. Till now, we have used, I don't have much data, and I do not have too much detail on my patients which we are using. But right now, we have 17 patients on which they are running, have been discharged. You can see from our experience, I can say if the patients whose lymphocyte counts are less than 20% on admission, Thymosin Alpha works very good in them. But in those who have lymphocyte count about 20-25%, we don't see such a drastic effect. Here you can see here on admission, the counts were 5.5%, and then they increased to 20.2. Here you can see they were 8.6%, then they increased somewhere 8.8 or 17. Here also they show a steady increase, and this was reflected in other parameters also in inflammatory markers. Not just the lymphocyte count increased, the interleukin value decreased, the ferritin level started decreasing, and most importantly, we were seeing the improvement in the patient clinical condition. Right now, see, we have one patient who showed a drastic effect, whose interleukin was on admission very much high. I think this was the patient 88.6, and on the 3rd day it came down to 4.6, and then now on the 3rd and 4th day itself, the patient is being shifted to room. So this was our experience that those patients who have an admission lymphocyte count less than 20%, Thymosin Alpha works well in them, good in them, and those who have more than 20, the effects may or may not be reflecting in the reports. Maybe because the patient's immune response is already very good, or the COVID burden is not so good. Before finishing, I would like to give you a brief idea what these two logos are demonstrating here. Basically, we run regularcrisis.com, which is a channel for those who are dedicatedly working in the ICU and emergencies, for the doctors, nurses, paramedics. And you can subscribe to our channel. And I'm very happy that this regularcrisis.com is now affiliated with Education Society of Bedside Intensive Care Medicine. It's a non-profit organization, and anytime you can go to the channel and can subscribe and see our videos or lectures for everybody working the ISVN. So this is the scenario. We are still trying everything possible in the COVID-19 pandemic to help our patient, and I am very happy that Thymosin Alpha may prove to a boon to the COVID patients and also to the septic patients in the coming months or year. Thank you. Now I think I'm opening for the forum.
Yeah, I will be now requesting our Adarsh Shetty to kindly unmute themselves, and I will be requesting the other doctors to please be on mute for the question and answer session.
I'm audible. I am not able to see myself.
Yeah, Dr. Gupta, you are audible. Yeah, there are many questions that has come up into the chat box. Dr. Navneet Badwa will be moderating the entire panel discussion. So I will be requesting Dr. Navneet Badwa to put up the questions for the panel.
Okay.
Yeah. I think it has been a quick, fast discussion on the contemporary issues. I think just to begin the discussion, one important perspective which clearly emerges is that, I think we have seen this disease evolve rapidly, and we are still trying to understand, I would say, the natural history of the disease, but definitely in few last months, I think it's very clear now what should be the therapeutic approach, but there are certain gaps which needs to be addressed. As a clinical pharmacologist, I would like to comment before we get into the specific question answers that I think we are getting now the therapeutics into a very precise mode. If we compare and contrast with the maps which are there or the therapies which are there, some of the therapies may or may not work. We are trying to understand now much more. But one thing is clear that immunological mechanism and the pathways of the disease and which pathways need to be targeted precisely are being postulated very strongly that a drug like Thymosin Alpha one will be very, very important, very, very critical, not just with respect to improving the outcomes as far as mortality is concerned, but also mitigate the progress of the patient. If patient is in mild, delayed to moderate to severe. With this, I think we can take some important questions which have been there. I would like to start off with the questions to Dr. Om Shrivastava first. That which would be the best suited patient first who we can see the response as far as Thymosin Alpha and considering the evidence base which is already coming through. Sir, if you are there.
Most at risk for complications. Mostly at risk. Now, when you say mostly at risk, the biggest risk factor, and all the evidence has come this way, the biggest risk factor is obesity. A body mass index of more than 29 is considered to be one of the risk factors of systemic complication, because obesity, especially a BMI of more than 29, is a state of permanent inflammation. And that is the kind of a state where there is an exhausted immune system to start with. So I know of people who are obese, who are smokers, who are alcoholics, who once they test COVID positive, they will come and tell me that, look, I'm doing fine, absolutely, I can stay at home. And you tell them that, look, you are going to collapse. If you're not careful, you're going to collapse. You don't say that in that many words, but you know that 7 times out of 10 in this category of patients, they are going to collapse. So the structure of any of these things use Thymosin is based upon your risk assessment, your assessment of who is going to be at a risk for complications. So it's not disease, metabolically uncontrolled hypertensive, coronary artery disease, hypertension, and other risk factors, and like I said, obesity. So it's not simply a matter of saying that this person's ferritin is more than 30,000 or interleukin 6 has gone to 15,000. It's more a matter of looking at the overall picture and assessing that this kind of person is very likely to go into a complication. And that is the kind of person where I would use Thymosin Alpha, because what I want is that the immunomodulation should start at a point where before COVID has its opportunity to be mischievous, you're able to settle down the immune system. That's where I would like to position Thymosin Alpha. Dr. Vadva?
Sir, I had one question.
Message is that perhaps earlier the better, not let the patient go from one step to another. That's what the learning perhaps is. Correct me,
Sir,
sir.
one question here.
Yeah, Dr. Mandal is
Yes,
having
that is
one.
correct.
Yeah.
Sir,
Dr.
looking in a broad perspective view, what is the one alarming factor, like taking sepsis in general and rise of cytokines? What is the first indicator? Is it the lowering of T cell where we should enter and think for thymosin?
All right. So, look, one of the things that I use in my practice in immunology is to do, a lymphocyte, not just a lymphocyte count, but lymphocyte enumeration. I'll tell you why I do that. When you look at the subpopulation of T cells, right, you are saying CD4 count percentage, that's one. But you also need to look at CD8 count and percentage, because CD4 are helper cells and CD8 are inducer cells. So when you've got a CD4 CD8 ratio, a CD4 CD8 ratio of less than 0.2 is a sure marker that your patient is going to go into a complication. A CD4 CD8 ratio of more than 0.3 is also a reasonably good marker that your patient will not go into a complication. So that is how, when you say, if I were to pick one marker and say that, look, this patient, is he likely to go into a complication? I'd like to see the lymphocyte enumeration. That means I'd like to see that patient's CD4 count, CD4 percentage, CD8 count, CD8 percentage, and CD4 CD8 ratio. That is probably going to be the one single test that will tell me that based on somebody who is, say, elderly, obese, hypertensive, smoker, chronic alcoholic, has liver dysfunction, renal dysfunction, all of those things that will impair or impede your patient's CD4 counts and CD4 functions. That is the person where I would use Thymosin Alpha.
Just one more question. Any other alternative than CD4, CD8, which is not available in most of the places? Any other sepsis indicator?
If you're going to count on something besides that, it will have to be your clinical assessment. It will have to be a clinical judgment, because whether you say ferritins or you say LDH or you say D dimers or you look at interleukin 6, all the other markers will be having a very in clinical acute infection. I don't know if there is a single marker that you can say that if the cutoff is, if say 500 or 1000 for a D dimer of more than 15-20,000 is good. You should use Thymosin Alpha. I think that if you don't have that kind of luxury
Thank you, sir.
I would do clinical assessment.
Dr. Om Srivastava, you have been one of the pioneers in identifying and a strong proponent of the fact, bringing this to the light, that coagulopathy is a very, very important differentiation as far as COVID pneumonia is concerned. Any specifics with respect to, because the literature says or hints, I would say at least, that there is some association between the coagulopathy and the risk for the patient landing up in sepsis. And if that be the case, would Thymosin Alpha would be helpful to mitigate not just the patient lands up into the complications like sepsis, but also the long-term sequelae like pulmonary fibrosis, etc., etc. Although this may be postulation, but what's your thought? You have a very rich experience on that front. Would like to hear your comment on that, sir.
So yes, definitely. I think there is a role of something like Thymosin Alpha in preempting when you know that this patient is likely to go into sepsis or this person is likely to go into severe, pulmonary fibrosis, or a vasculopathy of COVID, or simply liver dysfunction, kidney dysfunction, brain and spine involvement. All of these things are likely, and so yes, there is a role for thymosin alpha in preempting that. You don't want to wait for any of these complications to occur and then start thymosin alpha. Even then, I think that there is going to be some benefit. I'm quite sure there is. But you want to say that this person is likely to go into these complications and I'm going to start thymosin alpha. Ideally, if you were to look at, say, something like plasma, the best effect of plasma is in the first 1 to 3 days of the infection. Now, I know that's not possible for every other molecule, but like I was saying just before we came to this point, Dr. Vadva, is that if you are able to preempt that this patient is going to go into a complication, I would use the molecule as early as possible.
Dr.
Very well,
Om,
sir.
sir,
Yeah.
can I ask you a question?
There is a question
Sir,
from Dr. Rahul Bhatt. Sir, please go on. Please ask your question, please.
So we have seen all the immunomodulators, right from HCQs to IL-6 inhibitors to now thymosin is a new kid on the block in this way. It's not a new kid, it's an old kid, sir. So among all the
Yes, please go
immunomodulators, by
ahead.
your experience, sir, which is the best immunomodulator you would rate it as to be useful? So can you hear me? So which is the best immunomodulator? Hello.
Yeah, please go ahead.
So my question is over. Which is the best immunomodulator, sir, which you find to be useful amongst all the immunomodulators we have seen rise and fall in this 5 months of pandemic?
Again, when you're saying an immunomodulator, you don't want to suppress that part of the immune system which is protective, and you
Yes.
want to modify that part of the immune system which is going to be destructive.
Yes,
The
sir.
most appropriate immunomodulator will need to be able to balance these two. Now, when you say use a steroid, okay, well, a steroid will definitely work. It definitely works, but it is a very general, it's a very non-specific kind of an immunomodulator. When you say use something like any of the itolizumab or tocilizumab, you're again looking at something which is a monoclonal antibody. At least the itolizumab is a monoclonal. All of these agents work very well in selected kind of situations. But if I had to pick one to say, look, this is where you're going to course correct for COVID, it would have to be thymosin alpha. It would have to be the most balanced immunomodulator. And I think that we are going to be fine and be pleasantly surprised about the things that thymosin alpha can do. Of course, we'd like to see the evidence. It has to stand scientific scrutiny. But based on what we have seen in the last few months and from the limited experience of other people, other centers in the country, I think that thymosin alpha has a lot of promise.
Sir, I would like to highlight, because a lot of questions are there regarding dosage. I think I can just specify the dosage and then we can go on forward as the questions are evolving. I think one important perspective is the variability of the dosage with respect to the symptoms and how the patient presents. From the entire spectrum, right from prophylaxis to severe symptoms. For example, in prophylaxis, the recommended dose is 1.6 milligram. That's one vial subcutaneously weekly, twice for 4 weeks. And on the case of mild symptoms, one vial subcutaneous, that's OD, for 7 days. And perhaps that's also corroborative with the data what we have seen that. And also with moderate symptoms, 2 vials BID, that is 6.4 milligram per day subcutaneous for 1 week. And for severe symptoms, 2 vials 3 times a day, that comes to be 9.6 milligram per day subcutaneous for 1 week. I think that also reflects how immune fatigue can be replaced, perhaps the dosage variability. Any comments, sir, from Dr. Om Srivastava on that?
See, again, if you look at the dosing of a number of molecules which are in this kind of a situation where you're trying to do the best for the patient and try and get their immune system to be active as soon as possible, you'll find that in most of the trials in the last about, say, 15, 20, 25 years, in most of the trials, you start with a little bit of an overdosing because you are keen, you want to ensure that you are not going to be underdosing. That means you may want to have a benefit, but if you have underdosed that kind of patient, that benefit that you're seeking may not be available. So it is probably going to be a slightly bigger dose. My feeling is it is going to come down into a BD or a once a day dose, and that may be able to have the same results as a BD dose or a TDS dose. But that is my feeling. But let's wait and see what the evidence is for the next couple of months, and maybe we can decide from there. But like I said, in most principles, you want to overdose. If there is a safety margin, you want to go to the upper limit of the safety margin rather than being on the lower limit of the safety margin, because you don't want to be in a situation where you have used a molecule like thymosin and it has not given you the benefit that you are seeking.
And the safety profile of the drug is well established, sir. From the past 40 years, the drug has been used and not a single case of overdose has been reported. And we have a query from one of the participants. Can this Immunocin Alpha can be used as a vaccine enhancer? Any thoughts on that, sir?
Yeah, that's a very interesting part of your conversation, Dr. Shetty. Is it something that is going to be able to enhance the vaccine? Now, look, we don't know enough about the vaccine at this stage. We don't know enough about Thymosin Alpha also on the clinical parameters on the ground. I certainly hope that what you're saying is true. I hope that you're right. But we probably need to see, rather than having a monodirectional understanding of Thymosin Alpha and the vaccine, we probably need to see what the vaccine is doing. So when you come to the phase 3, where a vaccine is being given to not just a few hundred, but maybe 100,000 people in the community, what kind of effect this vaccine is having on the immune strengthening of the patient, and how much of that is being added to by the use of Thymosin Alpha. So like I say, I hope that you're correct, but I don't know enough. I think that all we are hoping right now is that both these points are appropriate and correct, but I'd like to see strong scientific evidence before I comment on this point.
So we have got one more query that recently the phase Covax has come, which has not shown any mortality benefit. So what will be the role of tocilizumab at this stage?
Sorry, your voice was breaking off, Dr. Shetty. You are asking me about mortality benefit of thymosin?
No, sir. Covax trial of tocilizumab has recently been published, which has not shown any mortality benefit. So what should be the role of tocilizumab right now, sir, in the severe cases?
Sorry, again, your voice is breaking off. I think I got some part of your question. You're asking me what should be the role of tocilizumab?
Yeah,
Sir, I'll reinforce the question. Basically, there is some evidences, trials which have shown that the mortality benefits with tocilizumab are clearly not there. And I also like to add up there that, there is, in fact, out of my own curiosity, I'm exploring the concerns and the red flags which have been recently raised with tocilizumab, especially with the severe GI perforations, which have not been perhaps reported at that much a major extent as it has been used in rheumatoid arthritis and other immunological conditions. So your current perspective on tocilizumab in the current context, there has been a lot of initial positive vibes about it, but what is the current status of tocilizumab in COVID, sir?
I'm sure we are all familiar with the largest trial of tocilizumab of about 450 patients that did not show any mortality benefit in COVID, at least. I think that's a big study. It's a very well powered study. I would pay attention to it because it is as of the immune dysfunction of multiple levels. There are probably about, I don't know, where the immune, if you've got one molecule that inhibits one part of the immune, the the other pathways are going to do what they are going to do is to keep an eye upon. So I think that the study about tocilizumab going to close my mind to tocilizumab. It definitely is an agent that works well. As to whether it's going to work well in all categories. So again, my own experience with tocilizumab is that it is going to work very well in the early and the mild to moderate disease. It does not work in the late disease. But early and mild disease, they probably would have gotten well without tocilizumab in any case. So I think that, you know, when we look at stratification of patients who are going to benefit from tocilizumab, we probably need to have a much better stratification before we can decide that this category of patients will benefit from tocilizumab.
Hello. We have got one more query, sir, regarding the adverse events of Thymosin Alpha and any overdose.
There's not a great deal of evidence that thymosin alpha is toxic in any major way, at least. There's in fact virtually no evidence that systemic implications. But you know, COVID is a very new situation. We should probably look at what kind of results we're getting with COVID and thymosin alpha. On paper, at least at this time, there's virtually no evidence about something like thymosin alpha having a long-term systemic effect on any of the patients.
Hello. Hello. Hello.
Regarding the indications of thymosin alpha can be used, because there are a lot more.
I'm sorry, can you
literatures?
please?
There are a lot more literatures which is showing that the thymosin alpha is used in HIV patients, since it increases both CD4 and CD8 count. So what are the options this thymosin alpha can be used, sir? So we have got a query whether it can be used in sepsis.
Yes, it probably can be used in sepsis, yes, but before a comment on sepsis is made, I think that's also going to require validation from a clinical trial that in sepsis it is going to make a difference at this point, not at every stage of sepsis, but at this particular point in sepsis, it is going to make a difference. So it can be used, yes, I'm quite sure it can, but like I said, it needs to be validated. And so once that is done, I think that I have a reasonably good feeling about it being used in sepsis. But like I said, you know, we don't do clinical practice based on somebody's good feeling. It probably needs to stand scrutiny, scientific scrutiny, and the test of time. And once that is done, I'm sure it's going to be having a role in sepsis as well.
Hello. Hello. Am I audible? I have a question. Hello. Hello. I am Dr. Raman Raj. I have a question.
Go on, sir.
Yeah. Do you have any RCT with Thymosin Alpha in COVID-19 patients or any guideline recommendation?
I think the question is.
So right now we are conducting trials.
Hello.
Hello. Right now we are conducting phase 3 trials, sir, on 120 patients, double-blind study, along with placebo. So we have selected 7 centers all across India. So 2 from Pune, 1 from Mumbai, and 1 from Delhi, and 1 from Belgaum, and 1 from Baroda, sir. So right now the trial is going on phase 3, and along with that we have conducted 2 more trials with Dr. Om Srivastava itself on moderate patients. And another trial which we are conducting is with Dr. Rahul Pandey in Fortis Hospital. So these are the 3 trials which are ongoing, sir.
Hello.
What is the cost of this Thymosin Alpha to the patient?
The cost of one vial is 2,000.
And availability?
Right now it's commercially available in all centers.
Okay. Thank you, sir.
And so we have got one more query that this Thymosin Alpha in pregnancy.
Could you repeat the question?
From the participant, the safety profile of the Thymosin Alpha in pregnancy and lactation.
Yeah, so I don't think there is a contraindication in either pregnancy or lactation, but because it is something that is new in especially pregnancy and COVID, I think that we might want to wait and see what the literature says. As of the evidence available before COVID, there doesn't seem to be a contraindication with either pregnancy or lactation with the thymus. But like I said, if you are going to choose to use it in COVID and pregnancy, I think you might wait before the evidence that we are hoping is there is actually corroborated by sound clinical evidence at this time.
So I like to point out very categorically that as you rightly said, because we don't have current evidence as far as pregnancy is concerned, the usage in pregnancy is concerned, but what the literature says, I'm sure it will be applicable to COVID as well. That animal studies, experimental evidences in mice and rabbits have not shown any differentiation as far as fetal abnormalities are concerned. Risk-benefit ratio, there is no differentiation as far as animal studies are concerned. And we do not know whether this Thymosin alpha is excreted in human milk. So the caution is what is being recommended that when it's being administered into when it's administered to a nursing woman, I think this will evolve. This is what it will hold, and in fact, I don't think so. We will not be having trials based on that because there are so many things to be ascertained as the things evolve. But I think one very promising thing, even Dr. Om Srivastava and other medical fraternity, I must congratulate the cases what we saw now. A huge a step forward in terms of having own evidences. In fact, we are looking forward that from our country, perhaps this would be the first publications which may come through, including the trials which are on, so that we can make it's not just about our Indian patients. The world learns from us in terms of the evidences which are coming up very, very fast and very, very soon. I think that's very important step in the right direction, that at least we have some evidences much more of what Dr. Ankur Gupta has shared gladly. In fact, medical fraternity getting the maximal benefits out of that. And this also brings to a very important point. There is a very strong documentation that in China, how the medical health professionals are able to still deliver the same standard of care and during COVID, that there has been administration of this drug to the medical health professionals, so they are confident and they are treating other patients without themselves getting at risk. So that's a very clear marker that the population, the medical health professionals who are at the highest risk of contracting COVID probably would also gain in terms of protecting themselves as a prophylactic modality is concerned, so that they can render their services to the huge population base. I think this is moving towards the precision medicine in particular. Any comments, sir? Dr. Om Srivastava and Dr. Ankur Gupta, because you have shown your own experiences, the first few experiences which have come up from the country.
No, I think it's reassuring. This evidence from Wuhan is pretty reassuring, although I must admit that how much of evidence are coming out of China is going to be believable. That's another question. That's another story. But based on good scientific evidence, it's reassuring to hear about the Wuhan doctors having taken Thymosin Alpha and not had any fresh outbreak. So I think I would watch that space carefully, but it's reassuring.
Hello.
But I think, sir, I in fact, this is a very rightly pointed out. In fact, I'd like to highlight that I worked on one of the meta-analysis what we submitted on 29 January. That was on the ongoing treatment of therapies for coronavirus. The COVID word did not exist on 29 January. All said and done, if you look into the evidence base, what China has come up with, it's hugely respectable, and it's not about the China evidence. This has gone through a tough peer review process in the impactful journals, and that's a promising thing. That most of the publications are in the American journals from the Chinese databases. That's an interesting phenomena there.
Hello. Hello.
Dr. Wadhwa, we will be going ahead with only last two questions now.
Hello. I'm Dr. Nagendra here.
Yes, sir.
Hello. Sir, in cases of severe COVID, when the patient is an hypoxic, when we have used all other medications like tocilizumab or remdesivir, and still the patient is hypoxic, and we can we use this thymosin alpha even if there is there is no lymphocytopenia? Hello. Hello. Hello.
So we have got a key that the patient is in severe COVID. It's not lymphocytopenia.
नमस्कार बोले सर ऑफिस काली जिबे
And so we have got one more query that why the children are less infected with COVID-19. Is it because of thymus?
Dr. Shetty, I'm not a pediatrician. I don't think I'm the right person to be wanting to answer that question. I can give you a theoretical explanation, but I'm not a pediatrician.
Dr. Om Srivastava, with your due permission, can I make a comment on this?
Yeah, absolutely. Yeah,
Sir,
please go ahead.
This is just an observation. What they have found in a pediatric population, probably the barriers to contract virus are relatively much stronger, and immunological basis to a certain extent, yes, observations only. But on the other side of it, it's being very strongly said that if children contract the virus, they become super spreaders, because then the other practices goes higher. But I was just looking that, comparing this with, there was an interesting perspective. Amitabh Bachchan, Aishwarya, and Aradhya. How the pattern of disease differed in that. It has been very, very famous in talk. But maybe I would say, maybe to a very strong observational data what I've read. Of course, no practical experiences, but again a postulation. There are some barriers on the immunological basis which actually mitigate those implications. Correct me if I'm wrong, sir.
Hello. Hello.
Yes, Dr. Nagendra, please go on. Yeah, this will be the last question. Please
Okay, sir. Thank you, sir. Thank you, sir. Sir, in a severe COVID patients, when we have used remdesivir or tocilizumab, and patients still in hypoxic state, when there is no lymphocytopenia, can we use this thymosin alpha, or is that underlying sepsis in after using these drugs can cause severe sepsis?
Yeah, I'm quite sure you can. I'm quite sure you can use it. I think more than anything, there is a single indication on paper. If there is a clinical situation where you feel that the immunomodulatory therapy of the infection is going to be benefiting the patient, and that sepsis also will come under control because of the immunomodulation, I can't see the problem in using something like thymosin alpha. It's a good molecule to be used. What you're discussing is just a theoretical situation. It's going to be a very, very happening situation in patients. So I would think that yes, people will benefit from thymosin in the situation that you're describing, Dr. Nagendra.
Okay, sir. Thank you, sir. Thank you.
Sir, one comment. I think it's not just the numbers that matter here. It's also the perspective with respect to the quality of the cells, which is alpha, the T cell, how thymosin alpha supports T cell differentiation and maturation, and also parallelly reducing the apoptosis of the cells. It's not just the numbers of that perspective. Entirely, the entire picture that holistically would really matter. Comments to Dr. Om Srivastava on that. That's what at least the evidence speaks clearly on that.
I think the audio quality is quite poor, Dr. Vadhwa, but just getting
तो
to
है ही नहीं,
the
चल
of
निकल गए
your
वो।
question, I think that it is
उसको तो पूछा था कुछ, उन्होंने तो आंसर भी नहीं किया।
it is possible. It's possible, but look, I think this is going to be the discussion for a completely different topic. I think this is probably beyond the scope of this topic.
Okay, with this, I'm asking the panel to, we are closing down the panel discussion over here. And I will just go through the my a short presentation of today's webinar. Okay, this webinar session was sponsored in technical collaboration of Gufic Biosciences Limited. For the audience over here, for any further queries, please write to info@guficbio.com. And this webinar was sponsored by Immunocin Alpha, that is lyophilized Thymosin Alpha 1.6 milligram per ml, which modulates immunity perfectly. We also invite you for the second webinar, which will be on 12th September, and the topic will be again on role of T cells, the unsung warriors in various stages of COVID-19. Our speaker will be again Dr. Om Srivastav. And again, I'm repeating, for any further queries on this webinar, please write to info@guficbio.com, and we will be reverting back for any questions you ask on the molecule Thymosin Alpha, that is Immunocin Alpha, our brand, and we will be coming back to you on that. And with this, I am handing over the session to our Assistant Vice President, Mr. Shekhar Ale, for his closing remarks.
On behalf of Gufic Biosciences Critical Care Division, I'd like to thank all delegates from India and Nepal for joining with us from your busy schedule to make this scientific program successful. We are thankful to Honorable Speaker Dr. Om Srivastav, case presenter Dr. Ankur Gupta, panelists, for giving your valuable time to make this webinar meaningful. Gufic Biosciences has taken the initiative to update the medical fraternity regarding the role of Thymosin Alpha for the benefit of patient. As the flagship bearer, Gufic has planned the webinar series, as Samrat has already briefed, on the vast role of Thymosin Alpha in various stages of COVID-19. Our next webinar is on role of T cells, unsung warriors in various stages of COVID-19, which is scheduled on 12 September, 7 p.m., led by Honorable Speaker Dr. Om Srivastav with new studies and case presentation. We'll let you know through our people. Again, we'll remind you. However, I take the opportunity to invite you all for the next webinar and looking for your valuable presence there too. Regarding the molecule Thymosin Alpha, if you are having any queries, as informed by Samrat, please mail to the given mail ID as info@guficbio.com. In India, Thymosin Alpha presently manufactured and marketed by only Gufic Biosciences Limited with the brand name of Immunocin Alpha. At the first stage, we launched at few cities as a trial, but with enormous response, with very positive response, we will make it available at rest of the countries and Nepal. Our field staffs will inform as soon as the product will be available at your town. Lastly, our sincere thanks to all for passing the benefits of Gufic's world-class quality products at affordable price to billions of patients. Once again, thank you all for joining with us. See you again on 12 September. Good night to all. Thank you very much.
Good night to all. Good night to all, doctors.